Hi, I'm Chris. I'm a respiratory therapist at Good Samaritan. We're here to talk about trachs today. So there's a couple different kinds. The main ones are Shiley's, standard ones. You'll see a bunch of numbers and letters. This is a 6 cuffed, 7.5 inner diameter, and it's a disposable cannula. We also have XLTs. They're a little bit longer for patients who are taller or patients with thicker necks. These are the main ones we use. In every kit, you get the actual trach tube, which has a cuff on it. The pilot balloon comes with an obturator, which is designed to use to put the trach in. And then it comes with an inner cannula, which you will insert after the trach is already in. So I'll go ahead and put this one in. In the event the trach ever comes out, the obturator is always in the room, and you put the obturator in the trach, which creates a nice beveled edge to where there won't be any catching of the tissue, and it will go in a lot smoother. So to put it in, kind of rock it into place. All right, so once the trach is in, you take out the obturator, do not throw it away, and you put in the inner cannula, and then you would attach the vent. But before you attach the vent, you want to confirm proper placement. That's by putting the colorimeter CO2 detector there and bagging the patient. Make sure you have equal chest rise and good color change on the CO2 detector. So then if the patient is not on a ventilator, we initially use a trach collar, which is the trach mask. It just goes right over the top like this. This is how you'll see a non-vented trach presenting in the ICU. To secure the trach, we have trach ties. They just go around the neck. To change these should be a two-person job once they get soiled, for one person to secure the trach while the other person puts it around the neck and through the slots. And just nicely secure it. And then it should be tight, but not too tight. You should be able to get 2 fingers under it so it's not too tight, creating pressure at the trach site or on the back of their neck. And then for drainage, usually fresh trachs will have some drainage. We always keep a gauze between the trach and the skin. Kind of like that. Throughout the day, as we're going, this will get soiled. Nurses can change this out at any time. Just simply pull it out. And then if there's any extra oozing or drainage here, you can get a trach care cleaning kit. And it comes with some gauze. And it comes with a brush. And it comes with, this is to clean the inner cannula. Don't use this on the actual patient. And then it comes with some sterile Q-tips. So if there's some drainage in there, you can take a Q-tip, dip it in saline, and then you can clean under here. Once you take the Q-tip out from under there, don't put it back in, use a different one. And then clean the other side, kind of get everywhere until it's clean. If you need more Q-tips, we can use the longer ones that are stocked in the C locker. That are just the Q-tips alone. So once you're done cleaning the trach, reinsert a new gauze. And as you're inserting this, depending on how fresh the trach is, the patient may wince. Just try to be as gentle as possible and eliminate movement on the trach because that stoma site is still raw and fresh. And they may cough a little bit during this time. That's okay. That's just movement of the trach stimulating that cough. So once the gauze is back in place, we can suction the patient. I usually suction the patient before we change the cannula, just so they don't get new secretions in the fresh cannula. So to suction, it is a sterile procedure. So every kit comes with sterile gloves. So once you have your sterile gloves on, you take the cannula, the suction catheter, and then you designate a clean hand and a dirty hand. So I would hook up my suction. This will be my dirty hand, clean hand. As you go in, just insert, try not to touch anything with the catheter. And you don't have to insert very far, you just go until they start coughing. Once they start coughing, pull back a little, hold the suction, and just slowly come out. And if you get quite a bit, you can go back in. If you don't get much, you can be done. The patient will cough during this. And then if you need more suctioning, just go in. You feel resistance, pull back a little, and suction out. Once that's done, you can throw this catheter away, take off your gloves and get new ones. And then to change a cannula, which the RTs will do this once a shift, you just simply pinch the cannula, pull it out, get your new one, and just slide it right back in. As you're doing this, the patient may cough during that too, so always stand to the side of the bed and never in line with the trach to avoid any secretions that will fly through the air. So then once that's done, you can put your trach collar back on. And then this just simply snaps on. So as the patient progresses and they have less secretions and they're more comfortable off the ventilator and on just a trach collar, we will switch them to a HME, which is a heat and moisture exchanger, and it just simply goes on the trach. You have a port for oxygen, so you can bleed in oxygen, and then you have a suction port right here. So as you suction, you don't have to take it off. It just goes right in, and you do the same thing. These have to be changed out every 48 hours. The RTs will take care of that. If you see a lot of secretions in there and you worry that the patient's struggling because of the resistance, you can just simply take it off. If you do that, call RT immediately because the patient won't have any humidity. But yeah, these work a lot better for patients who are minimal secretions, awake, and following commands and everything. And then as the patient progresses also and they want to talk, we have a passing mirror valve. This is just a one-way valve to where air can enter into the trach, but as they exhale, the air bypasses the trach and goes through their vocal cords, so then they can speak like normal. So that just simply goes on. It's press fit. The biggest safety thing for this is you always want to make sure the cuff is down. We do have a warning label that we tape around the cuff, and we have a bigger warning label that is placed above the patient's head in the room, which simply states make sure the cuff is deflated before you place an HME. The reason for that is they will be able to breathe through the trach, but then when they go to exhale, their upper airway will be blocked off with a cuff and their trach will be blocked off with a passing mirror valve, so they won't be able to exit at all. Okay, so to give you guys a better idea of what the cuff looks like, I'm going to take this trach out and show you. Now, the RTs will always inflate and deflate the cuff. The nurses don't need to, but it's good to know the function of it, especially when using a passing mirror valve. So this is a cuff that's deflated right now. As you put air in it, it inflates, and if it's sitting in the trachea, it will occlude like this. So reason why the passing mirror won't allow any air through the upper airway. And then as you deflate it, it will go flat, and then you have air movement around the trachea. So they can talk and everything like that. But just to state, when this is flat, the cuff is flat. When it's inflated, this is inflated. So when the cuff is inflated, the pilot balloon is inflated. When the cuff is deflated, the pilot balloon is also deflated. So this is your indicator if there's air in the trach or not, or in the cuff or not.